thank you all for joining us today for our first session of our Carol Pediatric Ophthalmology and Strabismus meeting. Inshallah, this will be a bi-monthly meeting prepared by the efforts of the team of Elreesh colleagues, from residents to lecturers and up to professors, assistant lecturers. Everybody is going to be joining. I hope it will be a fruitful and interesting meeting. Our aim is to طبعا ان احنا نتعلم من بعض وان احنا نشوف different cases. I hope everybody will enjoy it and benefit inshallah. Today we have 3 talks. أول talk هيبقى by Dr. Wael El-Sayyed, followed by Dr. Ahmed Awadein, followed by Dr. Youssef Helmy. With Dr. Wael, who will be presenting an interesting case. وائل
مع حضرتك يا دكتور. بعمل سكرين شيرنج. هنبتدي ان شاء الله الكيس برزنتيشن. Good evening, my dear professor and colleague. This is my case presentation for you. History of male child, 4 years, coming for checking for vision, full-term baby with positive consanguinity. He have late speech and the uncle had congenital cataract. Examination, bilateral clear cornea, poorly dilatable, refraction plus 15 bilateral, والIOB 13 في العين اليمين والشمال 14. And surprise, bilateral aphakia. This is the right eye. This is the left eye. بقية الإكزامينيشن والشيت بتاعه كان كل حاجة نورمال، مفيش أي حاجة abnormal فيه. بعتناه يعمل bilateral ultrasound. This is a photo of right ultrasound. Totally normal, aphakic, axial length 24. And this is the left eye, which retina in place, aphakic, axial length 24. Left eye or right eye 24, retina in place, normal appearance of optic nerve. Anterior segment OCT was done. This is the right eye. And anterior segment pachymetry for the right eye. Left eye, anterior segment, OCT, and left eye. Differential diagnosis. Congenital aphakia. I think this is the case of congenital aphakia. Surgical aphakia, post cataract removal in children. There was no history of surgical intervention for this child. aphakia due to trauma. ساعات بتحصل في التروما في الأطفال، ممكن يحصل لها اللينس، يحصل لها partial absorbed lens، بس ده ما كانش فيه أي history of trauma، أو trauma بسبب ال extrusion of the lens في الكورنيال rupture وما كانش فيه أي history من كده، والكورنيا كانت clear. posterior dislocated lens والفندس بتاعه كان normal، والألتراساوند مش باين أي posterior dislocated lens or subluxated وما كانش فيه أي subluxation باين لنا. الكلينيكال فيتشر السيمتومز ممكن يكون بليرنج اوف فيجن، الساينس ممكن يكون في سكار بريفيس اوبريشن لو كان عيان كان عامل قبل كده لينزكتومي او اي اي ديب اي سي. البركنجي ايمج بيبقوا 2 ايمج اونلي، والفندس اكزامينيشن ممكن نلاقي فيه posterior dislocated lens لو في عيان هيستوري اوف posterior dislocation. الكونجنتال برايمري افيكيا ده رير اي كونديشن، اللينس بتبقى ميسنج ات بيرث، ممكن يكون عنده other abnormalities زي مايكروفثالميا او انايريديا، anterior segment dysplasia، سكليروكورنيا. ده بيبقى موجود في من اول الاسبوع الرابع للخامس في fetal development، بيحصل ميوتيشن في الفوكس اي 3 جين، والموضوع ده بيبقى اوتوسومال ريسيسيف. البرايمري كونجنتال افيكيا بيبقى no lens developed at all، في حاجه ثانيه اسمها secondary congenital aphakia. اللينس بتبقى developed at some degree، بعد كده ممكن يحصل لها reabsorption او extrusion في عيان عنده corneal perforation before or during the birth، زي عيانين بيترز انومالي. الريبورتس المكتوبه كلها بتتكلم عن جين اسمه فوكس 3 جين، ده هو اللي مسؤول عن الكونجيتال برايمر افيكيا ان هيومن. وكان في كيس ستاديز قديمه بتتكلم عن البرايمر كونجيتال افيكيا في الروبيلا سندروم، وكل يعني الامبريوس دول ما كملوش، كان كلهم حاجات باثولوجيكال وهيستوباثولوجيكال اكزامينيشن واوتوبسي للعيانين ديت. ما كانش في حد كمل السن ده. هو في حد بس ريبورتد سنه 1968 ان في عيان 40 سنه ريبورتد ان هو كان عنده برايمري كونجيتال افيكيا وكان عنده ريتنال ديسبليزيا وهارت ديفكت. العيان ده كان عنده مايكروكورنيا، وكان الريفراكشن بتاعه بيوصل لاست 19 بيكوركت بيه ل 66، وفي العين الثانيه كان بيكوركت ل 6 18. معظم الريسيرش بتقول ان في دايما لازم يكون في anterior segment alteration او بيحصل زي corneal opacity او اي affection ان ما بتبقاش الكورنيا كلير في معظم الحالات اللي اتشافت فيها الكونجيتال برايمر افيكيا. الميوتيشن في الفوكس 3 جين بيعمل كونجيتال برايمر افيكيا في الاوتوسومال ريسيسيف على اوتوسومال ريسيسيف باترن. كان في هيستوري في باكستينيان فاميلي كان عندهم الفوكس جين 3 ديفيشنسي، وكان الاطفال بيجي لهم كونجيتال برايمري افيكيا. التريتمنت بتاعنا يعني واحنا كده مش يعني لغايه دلوقتي فور شور العيان بتاعنا مش قادرين نحدد هل هو ده برايمري كونجيتال افيكيا ولا لا. نقصنا بس ان احنا نقدر نعمل يو بي ام عشان نعرف هل العيان ده فعلا ما فيش اي لينس موجوده او ديسلوكيتد او سبلكسيتد في مكان تاني، بس كل الانفستيجيشن اللي احنا عاملينها ماشي ان هو برايمري كونجيتال افيكيا. فاحنا لو احنا بنتكلم على حد افيكيك عموما نقدر نعالجه ازاي؟ نعالجه بالثلاثه اوبشنز الموجودين عندنا، السبيكتكلز والكونتاكت لينس والاي او ال. السبيكتكلز ده الموست كومن، هو الاوبشن بيبقى شيب وايزي وسيلف ميثود. الايمج ماجنيفيكيشن بيبقى 30%، ده من العيوب. والسفيريكال ابريجن اللي هو البين كاشن افكت، والبريزماتيك ابريشن اللي هو الجاك ان ذا بوكس. السبيكتكلز مشكلتها الريستريكشن فيلد، وان احنا بنحتاج نعمل باي فوكال جلاسز ومش كوزمتيك وثيك وهيفي. والعيان بتاعنا بعد ما احنا وصفنا له الجلاس اللي هي بلس 15 الشكوى اللي كانت المين ان هي الجلاس فيري ثيك وفيري هيفي للبيشنت نفسه. الكونتاكت لينس مميزاتها ان هي ليس ماجنيفيكيشن، وايدر فيجوال فيلد، نو سفيريكال او بريزماتيك افكت، مور اكسبتبل كوزمتيكالي اند يونيكولار، بتنفع في اليونيكولار افيكيا. هي مشكلتها ان هي كوستلي شويه، وهي المشكله بتاعتها بقى سواء بقى البابيلا كونجنكتيفايتس او ميكروبيا كيراتايتس، سوبرفيشال مانكيتيد كيراتايتس، الكورنيال ألسرز عموما. الاوبشن بتاع الاي او ال سواء سكير فيكسيشن، بس ده لو احنا عندنا سالكس، وهو ده مش موجود في العيان بتاعنا، او يعني 3 بيس سالكس. ممكن سكير فيكسيشن ممكن في العيان اللي احنا شفناه مع بعض. ايرس كلو لينس سواء anterior او posterior inclination. take home messages: الكونجنتال برايمري افيكيا اكستريملي رير كونديشن، تقريبا 5 حالات اللي احنا شفناهم بس. والسبلكسيشن او dislocation of the lens should be considered first. Careful history taking and technical examination are mandatory. Thank you.
Thank you, Wael. Thank you very much. I would like to ask our panelists if they have any questions for Wael.
انا بس كنت عايزه اسال وائل، انت فعلا اتعمل له العيان دوت امبلانتيشن اي او ال امبلانتيشن يعني؟
لا يا فندم، احنا اللي وصفناه
احنا لسه شايفينه.
بالظبط.
اوكي،
لسه وصفنا
ويتنج
بس
بقى ان احنا نعمل له بعد كده ان شاء الله.
بالظبط.
تمام، ماشي تمام.
طب وائل اسالك what would you think is the best option for this patient?
بالنسبه للبيشنت ده اكتر حاجه هتبقى البيست اوبشن ليه السكير فيكسيشن او ايرس كلو لينس ريتروبيبيلاري، ده على ما اظن دي هتبقى احسن حاجه ليه.
Actually, I'm very glad you said that because inshallah next week برضو كده as a promo we have a talk about scleral fixation in specific برضو iris claw. بس يعني طب لو احنا عملنا iris claw at this young age يعني are you expecting يعني complications on the long run؟
ممكن يحصل dislocation للايرس كلو لينس مع اللونج بيريود، ممكن يحصل اتروفي للانكلينيشن بارت اوف ذا ايرس، ده من الكومبليكيشن.
اوكي طب هسألك سؤال تاني معلش، هو الفوكس 3 جين ده is solely responsible for length anomalies؟ يعني
هو مفيش اي جين تاني اكتشف، يعني ده كان كلها جورنالز جيناتكس كانوا بيتكلموا عن كده، يعني قصدي ان هو الديزيز نفسه كحاجه باثولوجيكال موجوده ان هو يتشاف لناس مكمله قليل قوي، معظمهم كان بيبقوا امبريوز خلاص زي انتراتيرين فيتال ديث وكده، فهم مجرد ان هم حاجه ريسيرش عليهم، لكن ان احنا نشوف سبيسيفيك بيرسون عنده الحاجات ديت فده حاجه فيري رير.
Okay, I'd like to ask our professors, يعني considering this child is highly highly hypermetropic since birth, are we expecting his visual outcome to improve? And he's 4 years now. Yani, what is the depth of amblyopia that we're expecting even if we give him an IOL and spectacles or bifocals? Yani, is this amblyopia يعني can we retrieve this amblyopia or it's not, it's going to be a deep amblyopia? دكتورة هالة. Ahmed, what do you think?
I think it will be amblyopia. I mean, the best corrected vision will depend on the best corrected vision with spectacles. So if he did not improve a lot with the spectacles, he would not improve also with the surgery. This is to my impression.
Okay, but of course he deserves surgery, although we know that implanting an IOL يعني carries a lot of hazards, especially without a sulcus or without يعني somewhere to implant it, whether an iris claw or scleral fixation, that we expect on the long term that he needs very close follow-up.
Quite hard to tell because, as you already said and the way I said, the number of cases in the literature are very few. So we cannot, of course, have any evidence whether the vision would improve in complications of some surgery or not.
Okay. Are there any questions, or maybe we leave the questions to the end, and maybe we can proceed with the talk, Dr. Ahmed Awadein, a very interesting and also another rare topic. Fadl.
Hello, everyone. I hope my screen is on.
Yes, it's fine.
Things that many of us don't understand and really don't like is understanding skew deviation and its relationship to ocular tilt reaction. Most of my talk today is quoted from the work of Dr. Michael Brodsky, so I'm very grateful for his work. Please, Rasha, can you mute yourself because I think there is a noise from your side.
Yes, sure.
The main control of the oculomotor nerves is based from the brain, but in addition, there are other centers that control the eye movement or the oculomotor nerves. They are called the supranuclear centers. These supranuclear control functions to coordinate the eye movement together, to control the response of the eye to change in the target position and speed, and to control the response of the eye to change in the head position. These supranuclear centers include the cerebral cortex, the cerebellum, and the vestibular apparatus. All of them function to coordinate and control the eye movement. Skew deviation and ocular tilt reaction are mediated mainly by the vestibular system. So how does the vestibular system control the eye movement? The main function of the vestibular system is to sense the head and the body movement. The main components of the vestibular system are the ventricle and the cule, which detect a linear acceleration or a static head tilt, for example, during the head tilt test, and the semicircular canal, which detects a dynamic head movement, for example, when you are riding a roller coaster. Now, these three semicircular canals function in order to detect the movement in all planes of space. There are three planes in space: the U plane, for example, when you turn your face to the right and to the left, and this is detected by the horizontal semicircular canal. The roll plane, for example, when you tilt your head to the right and to the left, and this is detected by the posterior semicircular canal. And the pitch plane, for example, a chin up and down position, which is sensed by the anterior semicircular canal. This is a short animation from the website showing the structure of this vestibular system. You can see that there are three semicircular canals, and below is the ventricle and skew. Now, each of these semicircular canals is filled with a fluid which is called the indolum. Semicircular canal, when you have a head tilt to one side, to the right or to the left, there is a movement of the indolum inside the posterior semicircular canal, which thus stimulates hair cells and sends impulses to the vestibular nerve. Now, on the other hand, when you do a chin down and chin up position, what is known as a pitch plane, you stimulate the anterior, or the other name for it is the superior semicircular canal. And finally, when you move your head to the right and to the left, you stimulate the horizontal semicircular canal. So when the vestibular system senses a movement of the head or the body, it will send impulses down the vestibular nerve to the vestibular nuclei in the brainstem. These vestibular nuclei then send impulses to the thalamus and to the cerebral cortex to allow the brain to sense the movement, to the oculomotor nuclei directly to push the eye to the opposite direction, to the spine to allow the brain to align the body posture, and to the cerebellum to coordinate all these movements together. What is relevant to our talk together is that whenever there is a body or head movement, the vestibular system sends the movement and sends impulses to the oculomotor nuclei to certain eye muscles. But which muscles exactly? If there is a first turn, the horizontal semicircular canal will send impulses to the ipsilateral medial rectus and the contralateral lateral rectus. When there is a chin down position, the anterior canals will send impulses to the ipsilateral superior rectus and contralateral inferior oblique. And when there is a head tilt, the posterior canal will send impulses to the ipsilateral superior oblique and the contralateral inferior rectus. So what I want you to remember is that the vestibular system will always send impulses to the superior muscles of the same side and to the inferior muscles of the opposite side once stimulated. So without a body movement, both vestibular systems will send equal impulses to the brainstem, and this will allow correct interpretation of the head and the body position. In addition, both vestibular systems will send equal impulses to the extraocular muscles on both sides, keeping the eyes alive. Now, what happens with the body movement is that the vestibular system on the side of the head movement gets stimulated, causing a sensation of movement and stimulation of the extraocular muscles to push the eye to the opposite side. So, for example, with the head movement to the right vestibular system gets stimulated, causing a sensation of a head movement to the right, and it sends impulses to the right medial rectus and to the left lateral rectus muscle, moving both eyes to the left, what is known as the doll head maneuver. The same will happen with the body tilt to one side, but in fact a bit more complicated. When you tilt your body to one side, you get a triad. You get a head tilt, a vertical eye movement, and a torsional eye movement. And this triad is known as the ocular triad or a physiological ocular tilt reaction. This triad is caused by stimulation of the vestibular system on the side of the body tilt. So, for example, when you are driving a motorcycle, for example, when your body is tilted to one side, the brain automatically corrects for this by tilting the head in the opposite direction of the body tilt. Now, the second change that will occur is torsion. When you tilt your head or body to one side, the vestibular system on the side of the tilt will get stimulated. And as I already said, it will send the impulses to the superior muscles on the side of the tilt, causing an intorsion of the eye on the side of the tilt, and will send impulses to the inferior muscles of the other eye, causing an extorsion of the eye on the opposite side of the tilt. We are, of course, familiar with these torsional changes in the three-step test. Now, the last change that would happen is a vertical movement of the eye, what is known as the physiological skew deviation. The problem is that the superior rectus muscle has a stronger vertical effect than the superior oblique muscle. So when both the superior rectus and the superior oblique muscles get stimulated, the superior rectus takes the upper hand and it pulls the eye upward. And the opposite happens on the other eye because the inferior rectus has a stronger vertical effect than the inferior oblique. So it will pull the eye downward, causing what is known as a physiological skew deviation. This physiological skew deviation is a vestigial remnant of the primitive otolithic writing reflex. It's present in animals like rabbits and in fish. When you tilt the rabbit or the fish to one side, the lower eye goes up and the higher eye goes down. However, in humans, this reflex is inhibited by the brain for the sake of binocular vision. So there's actually no physiological skew deviation. So to sum it up, whenever you have a body tilt, you get a compensatory head tilt, you get a compensatory torsion to correct for the body tilt, and you get a minimal or no vertical deviation because it is inhibited by the brain for the sake of the binocular vision. So in fact, it is not a true triad in normal people. It's only a compensatory head tilt and a compensatory torsion because there is nothing called a physiological skew deviation being inhibited by the brain. Now, the mediator of these changes is the vestibular system. So what would happen if we injure the vestibular system on one side? You will get what is known as a pathological ocular tilt. You will get the head tilt, the vertical eye movement, and the torsional eye movement, but this time it is caused by inhibition rather than stimulation of the vestibular system on one side. So the physiological is caused by stimulation, normal stimulation of the vestibular system, while the pathological ocular tilt reaction is caused by inhibition of the vestibular system on one side. So what would happen? By inhibition of the vestibular pathway on one side, you will get diminished impulses from the affected side to the patient who feels that his head is tilted to the normal side, to the patient who would tilt his head to the affected side in order to compensate for this. What is known as a subjective visual tilt. The patient perceives that everything is tilted to one direction. And the head tilt is towards the affected side. You can identify this subjective visual test by using a double matrix raw test in complete darkness in order to ensure that there are no vertical clues for the patient. You can also identify this by looking at the personal photos that the patient takes. You'll find that his photos are always slanted to one side. And by observing his handwriting, you'll find that his handwriting is always slanted to one side, up or down. Now, the second change that will occur is torsion, but this time it's the other way around. This time we have inhibition of the vestibular system on one side, so the head will tilt towards the affected side, but this time you lose the impulses to the superior rectus and superior oblique, so this eye will undergo an extorsion. And you will lose the impulses to the inferior rectus and the inferior oblique of the other side or the normal side, so we'll get an intorsion of the other side. So this means that the eye will tilt or will tort in the same direction as the direction of the head tilt. So it is as if that the torsion helps to fix the patient perception of subjective head tilt. Both the head tilt and the eye tilt are in the same direction. And finally, we get a vertical eye movement. Now we have loss of the impulses to the superior rectus on the affected side, so the eye will move downward, and loss of the impulses to the inferior rectus of the normal side, so the eye will move upward. So this means that you will get a hypotropic eye in the direction of head tilt. So the final appearance would look quite similar to a patient with superior oblique palsy, because you'll have hypertrophy in one eye and hypertrophy in one eye, and a head tilt toward the hypotropic eye, quite similar to what we see in the case of superior oblique palsy. And in fact, many of these cases are misdiagnosed as superior oblique palsy. But if you look carefully, you'll find that in patients with superior oblique palsy, there is an extorsion of the hypertropic eye, which is a hallmark for superior oblique palsy. But in skew deviation, it is the other way around. You'll find an extorsion of the hypotropic eye and an intorsion of the hypertropic eye. In addition, in superior oblique palsy, the subjective visual tilt is monocular, only in the eye with a palsy, while in skew deviation, the subjective visual tilt is binocular. Now, to further complicate things, not all cases of skew deviation are the same. They differ from each other depending on the site of the lesion. The most common type is the Comitant skew deviation, in which the hypertropia is equal in right gaze to left gaze. And these patients usually have a negative 3-step test, and these are the easiest to diagnose. But sometimes you might get an Incomitant skew deviation, in which the hypertropia increases in right gaze or in left gaze. And sometimes these cases are associated with a positive 3-step test mimicking a superior oblique or inferior oblique palsy. And the only way to detect them is by looking for the torsion, and you'll find an intorsion of the hypertropic eye and an extorsion of the hypertropic eye, which is different from what you would expect from superior oblique palsy. Now, a rare type is the lateral alternating skew deviation, in which you get an alternating hypertropia, a left hypertropia in right gaze, and a right hypertropia in left gaze. And this is usually caused by a bilateral lesion. And finally, we have the paroxysmal or intermittent type, which is caused by an irritative lesion that causes intermittent stimulation to the vestibular pathway on one side rather than inhibition. Now, one has to remember that whenever we are talking about the vestibular pathway, we are not only referring to the vestibular apparatus, but rather to the whole vestibular pathway, starting from the vestibular apparatus through the vestibular nerve, passing through the brainstem and up to the thalamus. And as for any nerve fibers, the fibers of the vestibular pathway cross in the pons. So if you have a lesion in the vestibular pathway below the pons, for example, in the vestibular nerve or vestibular apparatus, you will get the hypotropia and the head tilt on the same side of the lesion. But if you have the lesion above the pons, for example, in the midbrain or the thalamus, it will be the other way around because the fibers have already crossed the midline, so the hypotropia and the head tilt will be on the opposite side of the lesion. Thank God the skew deviation is self-resolving because it's quite complicated. The main treatment for cases that are resistant to treatment are prisms if there is any residual vertical diplopia. However, one has to recall that even if you use prism for vertical diplopia, the head tilt will remain because the prism would not correct the subjective visual tilt of the patient. Thank you.
Thank you, Ahmed, very much for this very tough talk. I think it needs some time to be digested, but it's very interesting what you said, that it's often confused with the superior oblique palsy, and I think a lot of us will confuse it. And is there one clinical sign? I think you mentioned the torsion, fundus torsion, right? That will okay.
Yes, that's why it's very important whenever you have an adult patient complaining of a recent onset vertical diplopia. Usually what comes to our mind is a superior oblique palsy. In such cases, you need to examine the fundus meticulously. If you did not find what you would expect for a superior palsy, you find that the eye with the hypertropia is intorted instead of being extorted, one might reconsider the diagnosis, and you might consider that the patient is skew deviation. In addition, it is quite helpful to examine the patient for any subjective visual tilt by doing a double Maddox rod. You'll find that both eyes have a subjective tilt, not only the eye with the palsy.
Okay. Is there a predilection to age? You mentioned that the lesion in the pons or maybe the vestibular apparatus, are we expected to see these more in old age patients, older patients, or it can happen in the young as well, young and old patients?
It has been reported in all age groups because sometimes it occurs in the setting of multiple sclerosis and associated with internuclear ophthalmoplegia. And the studies have reported that at least 2/3 of the cases who have internuclear ophthalmoplegia also have a skew deviation. So it's quite common in older age and in younger age, but it's because of different etiologies.
Okay, but the onset is not a long-standing onset. It's something that happens more or less acutely, or
usually it's an acute onset. It is usually differentiated from the acquired cerebral palsy, not from the congenital type.
Yes. Would any of our panelists like to share or have any questions?
There is a question about nystagmus with skew deviation. Yes, sometimes in skew deviation you get a torsional nystagmus. This is one of the audience is asking. And another question, whether the head tilt will disappear on covering one eye or not. No, actually the head tilt will not disappear because it is bilateral. So it is present because of both eyes. So even if you cover one eye, you will still get the head tilt. I think I answered both.
Can I ask Ahmed, is skew deviation, is there, because ear problems like labyrinthitis and things like that, and they experience vertigo. Do these people have skew deviation?
Sorry, Rash, I have a problem in hearing you. Can you repeat the question, please?
Okay, can you hear me now?
Yes, better now.
I was asking about patients who experience vertigo or who give a history that they have vertigo. Do these patients have skew deviation?
Not necessarily, because usually whenever one mentions a vestibular pathway, you think of the vestibular apparatus, but it does not always involve the vestibular apparatus. It might involve the vestibular nerve, the centers in the brainstem, or even the thalamus. So it's not always associated with vertigo or a problem with the inner ear. Only like a minority of the cases. Most of the cases are actually have a neurological cause rather than a problem in the inner ear.
Okay. Any of the panelists would like to share anything? Okay. Our next talk is Dr. Youssef Helmy. He will be giving us a talk about macular hole in children. Youssef, you can share your screen. We can't hear you.
Can you hear me now?
Yes, now I can hear.
So my talk, hopefully very quickly, is a quick review of the management of traumatic macular holes in children. And we went back to the literature to try and answer the question, is it better to do surgery for these children or to watch and wait, and when to do surgery for them? So this is a picture from the literature, a large macular hole in a 10-year-old girl who was hit by a football. So, and she's coming with her parents with sudden visual loss in the left eye. What should we do? So the best way to answer this question is to go back to the literature. There are two options: either do a quick vitrectomy or observe and then decide to do a vitrectomy later on if the hole does not close spontaneously. So we did a PubMed search for all the articles in English on traumatic macular holes till 2017. Actually, from in 2018, there was one publication, 2019, one publication, and 2020, 3 publications. So we're going to add them soon, but they haven't significantly changed our results. And they, from 1995 to 2017, there were 27 papers that discussed these. And as you can see, all of these, nearly all of them were case reports that looked at a small number of patients, and we pulled these patients together and tried to aggregate their evidence to reach the best way to manage these children. So first of all, in the studies that we showed, there were 105 patients. The mean age was 12.8. There were 80 males, 15 females, and the rest were unspecified. So most children who have traumatic macular holes are boys. 104 of them had closed globe injuries, and only one patient had an open globe injury. Most of them, 2/3 of them, as you can see here, were sports related, 63%. 24% were caused by weapons or violence, and 13% were miscellaneous causes. So with sports-related injuries, we have most children presenting with soccer or football. 33 out of the 59 patients were caused by large balls. Then we had 16 patients with baseballs, three patients with tennis balls, and the rest of the patients with smaller balls. With weapons, violence, abuse, and accidents, these were 23 out of the 105 patients. 5 had BB guns or firearm related. 4 of them were caused by punches, kicks, and fingers. Then we had, of course, shaken baby syndrome, which caused one patient, baseball bats, motor car accidents. Then there were miscellaneous causes. There is a slipper, a cork, corn on the cob, frozen tomato. There were these very miscellaneous causes that were reported, and they were the least prevalent in the aggregated literature. Now, when we looked at the literature, there was a group of patients who were managed mainly by observation, and the holes closed spontaneously. And these were 28 out of the 105 patients. The mean age here was about 14 years, 26 males and 2 females. And most of them, once again, were sports related, 22 out of the 28, and the remaining 6 patients were 2 patients caused by violence, 2 caused by miscellaneous and unspecified blunt trauma. The baseline characters, the mean visual acuity was 0.13 decimal, ranging from counting fingers to 624. The mean size of the average size of the macular hole was 300 microns, and most of them were 300 microns, around 300 microns in size. 17 eyes had no PVD, and 11 eyes that it was not specified, and 1 eye, and this is actually quite interesting, had retinal detachment, and despite that, the patient was observed and the hole closed spontaneously. So the mean time for hole closure, the mean post-hole closure visual acuity was 612, ranging from 660 to 6.6, and the mean time for hole closure was 11 weeks, ranging from 1 week to 36 weeks. Most children who were observed showed hole closure at 16 weeks, so 4 months and the hole closed. Most patients. The other group that we looked at were the patients who had vitrectomy following observation, following a variable time of observation. This was the remainder of the patients. So most of the patients here, 77 or 73% of the study. The mean age was 12, similar to the mean age in the other group, which was 13. 54 males, 13 females, and the 10 unspecified patients were in this group. And you can still see that sports-related injuries, because they are more prevalent, were more, but you can find that there is a disproportionately large number of patients with violence-related etiology that were in the group that were operated upon. Once again, the baseline characters were more or less similar to the other group. The baseline vision was 0.13, ranging from hand motion to 612. Baseline hole characters, the mean was slightly larger, 410 microns, and the mode, once again, most cases had holes, average size holes, 300 microns. 19 eyes didn't have PVD, 58 eyes were not specified, and here there were 3 eyes that had retinal detachment. Now the post-hole closure visual acuity, the mean was 0.42 and ranged from counting fingers to 6.6. The mean time to observe the holes before hole closure was 14 weeks, ranging from 1 day to 168 weeks. And the mode, once again, most patients, the mode which tells us how most patients were managed, were observed for 4 weeks and then operated upon. There were some adjuvant procedures like ILM peeling, gas, or silicone oil tamponade. And with the older studies, you'll find the use of serum and transforming growth factor beta, which have fallen out of favor nowadays. So when we looked at all of these different reports, we began to understand that the pathogenesis of traumatic macular hole in children was not related to PVD specifically, like in idiopathic macular holes. The idea that most cases PVD was not reported, and when it was reported, there was a large number of patients that did not have PVD. Now, these studies usually report hypothetical pathogenesis, like the issue of direct foveal rupture, cystoid macular edema with degeneration, choroidal rupture, or subfoveal hemorrhage. However, these are all hypotheticals, and there isn't enough evidence to prove that this is the actual pathology in traumatic macular holes in children. Now, we need also to take these results with a grain of salt. First of all, there is some missing information. Not all studies reported PVD. Most older studies before spectral domain OCT reported hole size in this diameters. I would assume that this diameter is 1500 microns, and then I would convert them into microns. Vision was not assessed in a standardized fashion. Most studies would report logmar, and then I would convert them back to decimal. And all of these studies were case series, so they are not actually very strong when we look at them from the evidence point of view. There were no randomized trials comparing observation head-to-head with early surgery. But how can we use this evidence? This is the actual question that as clinicians we need to answer. First of all, it's interesting to use this evidence to counsel parents based on evidence. So if a child comes with traumatic macular hole, I would tell the parents that for every 4 children presenting with a traumatic macular hole, the probability is that 3 of them will probably end up having surgery, just based on historical evidence. Most children who will have spontaneous hole closure will be observed for 3 to 4 months. So it's reasonable to wait for 3 to 4 months if you're confident that the child will come back for follow-up. Some holes can close within 1 week, so you can be optimistic. At the same time, they can close as late as 9 months. And if you wait for a hole to close, or if you do early surgery based on our skimming through the literature, the mean final visual acuity is more or less similar. So with holes that close spontaneously, the final mean visual acuity was 612, and after visual post-planar vitrectomy 0.42, which is between 612 and 618. These studies also give us insights into how surgeons think. If you look at the post-planar vitrectomy group, there were more holes that were larger than 600 microns. With the observation group, there were more holes that were less than 200 microns. Can we infer that a smaller hole is an incentive for observation? If we also look at the mode of trauma, you'll find that there was a large group of patients in the surgery group that were caused by violence, abuse, or accidents. So is a decision to perform surgery maybe sometimes incentivized by the more violent cause of trauma? And finally, we found that some surgeons performed a vitrectomy as early as 1 day after presentation, and some of them as late as more than 2 or 2.5 years after trauma. So this also gives us an insight. Some surgeons will never surrender and will go in to do a surgery even if it's after 2 years from the trauma. So our take-home messages: the commonest cause of pediatric traumatic macular holes are sports-related injuries with larger balls. Boys around 12 years are more commonly affected. Pediatric traumatic macular holes can be observed for 3 to 4 months before a decision for surgery is taken. PVD is usually absent. This is very important. You need to go in and induce a PVD, which is usually quite difficult in these children. And final visual acuity does not appear to be different if holes close spontaneously or after post-planar vitrectomy. Thank you very much.
Thank you, Youssef, very much. Youssef, I want to ask, please go ahead. Ahmed, please go ahead.
Just a tiny question about the visual outcome of macular hole. I mean, can we predict which patient will have a good visual outcome or not? Is it like idiopathic macular hole when it's related to the vision, related to the size of the hole, to the duration, or there are no predictive factors for the visual outcome?
I mean, this would be my personal answer without going back to the literature, because these papers don't give us any insight about this. But I could put two opposing issues. I think where it's similar to an idiopathic macular hole is the issue of the edge of the hole. If the edge of the hole shows fluid, if it's an elevated edge, this is more likely to have a better visual outcome because it's more likely to close anatomically without fibrous tissue or gliosis. On the other hand, there's the issue of amblyopia and visual interruption in younger children. I think this is an issue. Sometimes you have a good anatomical outcome, you've closed the hole, or the hole has closed spontaneously, but there is scarring, or there's been a long interval between the time where the trauma happened and when the hole closed, and this might influence the final visual acuity. But to my knowledge, there isn't a way to accurately predict just by an OCT, for instance, if this would have a better visual acuity or not. Sometimes there is also subretinal fibrosis, subretinal hemorrhage, which cause detrimental effects to the final visual acuity.
Oh, actually, you answered the questions. People are asking about the amblyopia and while we're waiting for the whole, if there will be a spontaneous closure. So do you advise that نحن نعمل amblyopic treatment during this part of time?
I think this would influence the decision to wait for a long time, and I defer back to the pediatric ophthalmologists. If we wait for 4 months in a 4-year-old, would this be very amblyogenic? Or if we're weighing the options, if it's likely that this hole will close. If it doesn't close after 4 months, I think we'll go ahead and do surgery. So this four month window, how amblyogenic is it for example, for a 4-year-old?
Youssef, I want to ask you another question. Of course, you said that there's spontaneous, or there's an incidence of spontaneous closure of this hole in children. We don't see the same picture in adults, right?
Yes, it's different. This goes back to the issue of pathogenesis. In idiopathic macular,
even though if the reason in adults is trauma?
No, if the reason in adults is trauma, then it behaves like children. The same traumatic hole generally, even in an adult, is usually not caused by PVD or not caused by anomalous PVD with centripetal or centrifugal forces opening the hole. With trauma, there is you could say there is a rupture of a cystoid space, for instance. So it's totally different.
This is Bardo, another question. Is there any communication, any relationship, between this patient after trauma developing commercial retinal and getting a traumatic hole later on? Would it be a macular hole?
The hole, yes. It might be the first step before a hole. Ahmed.
Yes, I have a question. If the pathology is not an actual PVD or pulling on the edge of the macular hole, then how would surgery help the patients?
Sometimes doing something is better than doing nothing, I think. Okay. Maybe because you're relieving some of the pressure, some of the forces inherently present, which are physiological, you're removing them. And maybe I'm totally wrong. I actually don't know.
What surgical option would you do for a traumatic macular hole in a child? The same as an adult? Would you be?
Yes. This is interesting also. The papers, most of them, if you looked at our studies, most of them are very old. They're 1990s, and so there was no ILM flap then. There was no ILM peeling even then. So they were using plasmin and transforming factor to detach the hyaloid. I think nowadays you would be more likely to try and peel the ILM and then invert it, or even do a free flap ILM. Once again, this is not evidence-based, and I think most surgeons would do this because this is what they would do for an adult, and it seems intuitive, even if it's not evidence-based.
Yeah, but this is assuming there are forces on the edge of the hole pulling on it, right?
Yes, yes.
So we have questions. We have the question, maybe it's a joint two question. When would you expect the visual acuity to be stabilized so that you can actually say post-surgery that this child has benefited from the surgery or not? How long would you wait after you perform surgery to say that his visual acuity has stabilized? And what would your expectations for with visual acuity post-op.
And I'd have to go back to the papers, but most of them report after at least 6 months. Most of the papers reported final visual acuity after 6 months. But then again, as I said, I have to go back and see, because some of them reported after a year or more. So I think patience is very important here. Once again, most of the time we're treating an anatomical condition. If the hole closed, most vitreoretinal surgeons would be happy if the hole is closed, and then it will be a waiting game for the vision to regain, understanding that sometimes vision won't be regained even if the hole closes.
I think one of the most important things we have to say for all of us, especially those with children who play sports with balls, we have to wear our protective glasses during sports. So again, I would like to ask the panelists or anybody who would like.
بس كنت عايزة أسأل حاجة يا يوسف. يعني أنت دلوقتي عندك patient with traumatic macular hole، إمتى هتقول له إن أنا هعمل، يعني هتعمل observation، وإمتى هتعمل surgery؟ إيه الكرايتيريا اللي هتخليك ماشي في الاتجاه ده أو ده يعني؟ وإمتى أقدر أقول إن أنا محتاجة immediate surgery مثلا؟
I think if there's lateral detachment, we wouldn't wait. It's very weird that there is one report of a patient where they waited with lateral. So if there's lateral detachment, I wouldn't wait at all. If it's a very large hole, if it's a very large atrophic hole, I would be reluctant to do surgery because I wouldn't be sure I'd give them benefit. Like if we're talking about an average sized hole, a 300, 400 micron hole in a child, I would wait at least 3 to 4, يعني between 12 to 16 weeks. If the hole is showing and I'm following up, I'm following them up serially. So if it's getting smaller and smaller, I'm waiting more and more. By the 4 months mark, if there isn't significant reduction in size, I would go in and do surgery then, understanding that I haven't probably sacrificed in final visual acuity by waiting these few months, based on the evidence.
طيب لو حصل spontaneous closure بعد وقت قصير قوي، هل انت تعمل له فولو اب بعد كده برضه؟ يعني هل في اي possibility ان هو يحصل تاني بعد كده بعد السبونتينيوس كلوجر؟
لا، هفولو اب عشان خاطر الفيجوال اكيوتي والمايكرو هبقى انترستد اعرف بقى الفيجن الفانكشنال اسبكت بتاعه، هل هيحصل ري اوبننج ولا لا؟ مفيش there are no reports the ones I read about a whole reopening غير الايديوباثيك هولز. الايديوباثيك هولز sometimes reopen، لكن I didn't see in the literature this. It might be there but I might have missed it. Oh, there's another issue برضو, and sometimes these children something else is missed which is very important to exclude, زي dialysis or giant tears in the periphery. These have to be excluded. So even if the child is coming with an attached retina and a traumatic macular hole, sometimes the biggest problem is a dialysis or a giant tear that's about to detach.
تمام، شكرا يا يوسف. شكرا.
Thank you, Youssef. Don't forget to send your patients for amblyoptic treatment work.
Yes.
Okay, I would like to thank everybody who attended today, and I would like to thank Dr. Ahmed for his great effort, and Wael and Youssef for their great presentations. And I'm hoping we're going to have many more of these very nice, interesting scientific meetings. Thank you all, and have a good night.
Have a good night. Bye-bye.